Okay, we'll give it to about 6:04. We are expecting quite a bit more people to show up here, so I'm hoping they're not having any issues logging in. Jeff, thank you. I can see you put a one in the chat. Okay, we do have a couple people joining in here now. Thanks for joining us, guys. You are at the right spot. If you have joint pain and you're looking to learn more about how regenerative medicine can help you alleviate that joint pain, today we will be talking about a few topics in the regenerative medicine field, which will go over arthritis. We'll go over hyaluronic gel injections, PRP therapy, and stem cell therapy. And our speakers today will be Dr. Tony and Dr. Domingo, and they both work at the Naperville Rehab Clinic, which is located at 445 West Jackson Avenue. If you guys can hear me and you're from Naperville or from the Naperville area, would you go ahead and put a 1 in the chat just to let me know you can hear me? Your mics are working okay, your speakers are working good, and let me know if you're from Naperville too by putting a 1 in there. Okay, great. So before we go too far, much further down the road, I just want to say that my name is Matthew. I've had the distinct pleasure of working with Dr. Tony and Dr. Domingo over the course of the last 2 years, working with them to handle customer service and their marketing. It's been a great pleasure for me to work with these two individuals. They're both extremely good doctors, they're well-renowned, and they're also both really good people. So I've had a really good time working with these guys and getting to know them more and more as we continue to work together. And Dr. Tony will be our first speaker for today. He's going to go over arthritis in general, and we'll go into hyaluronic acid treatment for the alleviation of joint pain. Dr. Tony has been working out of the Naperville office for the last 25 or more years. And that office is located, again, at 445 West Jackson. It's right across from the Riverwalk, if you're familiar with the downtown Naperville area. So if you guys are from the area and look to drop by, it's an excellent office, and it's a beautiful location there. So without further ado, I want to give the speaking over to Dr. Tony now, and he will go and begin the presentation here for stem cells. Okay. Thank you all for being here. Again, if you have any questions during the presentation, please feel free to ask. There's a Q&A icon at the bottom of the webinar screen. You can use that to ask any questions, and you could also ask any questions in the chat as well. We'll do our best to answer them. So thank you, and here we go, Dr. Tony.
Thank you, Matt. Thank you for everybody for joining us. Again, my name is Dr. Tony Maksudi. I'm a CEO of Naperville Rehab and Medical Clinic. I am basically warming you guys up for the next doctor, Dr. Domingo. He's our expert in stem cells and regenerative medicine. I'm just going to basically give you a little bit of an introduction, telling you where I came from. I was actually a computer programmer prior to becoming a doctor. I thought that my calling was to help people, as many people as I can. I had a couple of clinics around Midway Airport prior to coming to Naperville Rehab Clinic, and it's been nothing but blessing. If you are familiar or are from Naperville, this is exactly where my location is. The building on the right-hand side is where the building is, our clinic is. It's been there for over close to 47 years. I'm the second owner. The first owner, he retired, and he is golfing in Mexico, and sometimes he's actually in Phoenix. Our clinic is basically an integrated clinic. So we have chiropractic, we have nurse practitioner, we have neurologist, and again, regenerative medicine, and physical therapist and massage therapist. And we basically integrated, try to keep everything all under one roof for patients' convenience. And if you have been to Naperville for past few days, you notice that picture on the left-hand side, you're gonna see a lot more water. We're a little bit flooded over there right now. Okay, today's topic is how to alleviate your knee pain. How many people over here have knee pain or hip pain or shoulder pain? Go ahead and put in the chat. Put one. That kind of gives me indication of who wants to hear more about one subject. Right now, from what we saw and from the last seminar that we did, there was a lot more knee pain. So we decided this one is going to be about knee pain too. So we're going to explore the options and treatments and management of the of knee pain and due to arthritis. And we know some of those managements that people have gone and done. Some of it is physical therapy, pain medications, hyaluronic acid injection, PRP, and stem cell, which the last three are the newest and the best prior to getting surgery. So people who don't want to have a surgery, this is the option for them. And that's what we brought into our clinic to help as many people as we can. So let's talk a little bit about the normal structure of the knee joint. You have the femur, which is basically is your thigh bone. You have a tibia, which is your shin bone. Your patella, your kneecap right in front of it, and there's a groove right on the femur, and there's a little bit of a ridge on the patella. That patella goes over the groove fairly smoothly, and there shouldn't be any kind of a pain. Sometimes you get a pain if it is misaligned, so it's a mechanical issue. You have an articular cartilage, which is basically the cartilaginous tissue. That's the part that it breaks down and it causes what we call arthritis, osteoarthritis, and we're going to talk a little bit more about that one. We have on the inside of your knee, you have the medial collateral ligament, and outside you have a lateral collateral ligament. Those are so your knee doesn't buckle side to side. And of course, you have the anterior cruciating ligament and posterior cruciating ligament, which it goes from the femur to your tibia, and so it would help for your knee not to buckle forward or backward. And of course, everybody has always, you've heard that about the meniscus tear. That's basically, it's almost like a washer. It's like a cushioning. It's a cushioning between your femur and your tibia, which is your shock absorber. So that's one tissue that I say, let it heal and don't get meniscectomy or, surgery for meniscus. So let's talk a little bit about the knee osteoarthritis. We know that more than 40 million people in the United States have knee pain. More than 300 million doctor visits each year due to osteoarthritis. And we see quite a bit of it ourselves. And hundreds of millions of dollars each year is billed to insurance for treatment of osteoarthritis. And some of it is coming out of our own pockets. And there's a dramatic increase in total knee replacement in the United States. And we really truly can't explain why this happened in past decade or so. We don't know if it's because we are more sedentary. We don't know if it's because we're gaining a lot more weight. Is it because of our diet? Or is it more trauma we're going through? We just can't figure it out, but we know that there is the total knee replacement rate has gone up. And according to CDC in 2013, that was a while back, close to 750,000 total replacement surgeries has been performed in this country alone. And an American Academy of Orthopedic Surgeons predict by 2030, almost 1.3 million total replacement would be performed in this country. And that's a lot of knees to be replaced. That's a lot of knees that it's been damaged, and we don't know exactly why all of a sudden the numbers have gone up. Today's goal over here, what are we going to talk about? And of course, as I said, you're going to have to look forward to what Dr. Domingo is going to talk about. Today's goal is give you the options, other options for you to not to be one of those statistics. Try to save your knee as much as possible. So let's talk about a little bit about, what are some of the causes of the knee pain? Okay. It's either bones, joints, or your soft tissue. If it is arthritis, we're talking about the bones and joints, and that could be degenerative arthritis, it could be post-traumatic arthritis, it could be rheumatoid arthritis, psoriatic, which is autoimmune disease, which means your body is actually attacking your own tissue, is breaking it down because there is no negative feedback mechanism. Of course, there is always a soft tissue, and it could be ligament injury due to, it could be sports, it could be a fall, tendonitis, overuse, it could be meniscus injury, instability in an IT band or iliotibial band, and we're going to talk about that a little bit later on. On the right-hand side picture, you're going to notice that on the very, very top of the thigh, it says this is some of the causes of a knee pain, not necessarily all the causes of knee pain. So what you see is a lot over here, but still, this is not the total causes of what knee pain might be. So if you have a knee pain around right on your patella or your kneecap, you're talking about that. You know, could be bursitis, could be, you know, patellofemoral ligament issues. It could, if it's a little bit on the right-hand side, you know, inside of your knee, it could be meniscus tear, it could be osteoarthritis. And around 70 to 75% of the time, if you have a pain on the outside of your knee, and sometimes you feel like you might be traveling up towards your hip area, it is your IT band or iliotibial band that is a tightness over there, causing a little bit of a pulling on the outside of your knee. And those are the simple things that can be addressed and looked into and, you know, fixed without doing any kind of a, you know, surgery or, you know, any kind of invasiveness. A little bit of physical therapy, that could be fixed up. Some of the characteristics of osteoarthritis, I'm sure every one of you have had some of these if you have osteoarthritis. Pain. Number one thing, pain. Of course, the pain is the first indication that there is a problem. And it is your, in a way, it is your body's self-defense mechanism. It is your body's telling you there is something wrong. So your body is actually giving you an indication, hey, I need some help. Most people, they let it go till it goes from stage, you know, beginning or mild stages to moderate, and when it comes almost severe cases, they want to get some help. And our job is to tell you, hey, you need to get after it right away before it gets really, really too bad. So pain is number one thing. Of course, when there is a pain, you're going to see some swelling because of due to the inflammation, and of course, limited movement of the joint because, well, it's painful if you move. So what you try to do is, you know, modify your activity. So it's going to be a limited amount of movement into your joint. You don't want to move as much. And you notice that usually it's, you know, you're sitting, you might feel a little bit better. When you stand up, you're going to feel a little bit of stiffness. You start moving, you have to kind of get yourself situated. You start moving, it feels a little bit better. It gets almost gets lubricated. You walk, it feels better, but the longer you go, the worse it gets. And that's one of the telltale signs of osteoarthritis. So traditional treatment of the knee joint for osteoarthritis, you know, you've been told, of course, I'm sure just about all of us have done, you know, use heat or cold. You know, you've been told and you've done exercise, walk, swimming. Swimming is the best thing, by the way. I love swimming just because it is non-weight bearing and you're buoyant when you're doing exercise. Weight control, which is most likely is more of a weight loss rather than weight control. They want you to take as much pressure off as much as possible to your knee joint. Medication, over-the-counter medication, some prescription opioids, and of course, we've done some physical therapy. If you're still feeling the pain, they send you, a doctor says, okay, come on over, let's get you some steroid injection. And sometimes it works for a short period of time, and sometimes it doesn't. Of course, then it comes surgery or knee replacement, that's what we all try to avoid at this time. So if you look at the x-rays right here, some of us can identify with this x-ray. On the left-hand side, you're gonna notice the normal knee joint. There you don't see any osteophytes. The knee joint between the thigh bone and your shin bone, the space in between is fairly open and it's nice. And so you know the cartilage, the meniscus. On the x-ray, you don't see too much of it just because it is soft tissue. But the larger, the bigger the space it is, the better it is. That means there is some soft tissue is still there. And when you come and look at on the right-hand side, this is the one that is osteoarthritis in this one. So you notice the knee joint, the joint space is narrowed. You're going to see a little bit of osteophytes, a little bit of what we call a sclerosing, which is basically the body is going through a little bit of a depositing a little bit of more bone around that area for stabilization. But still, this is not what we call bone on bone because you still see some joint spaces over here. when you see some of the orthopedic doctors, they kind of like to, do the surgery. So they would call this as a bone on bone. Bone on bone is almost like misnomer, because if it was bone on bone, you wouldn't be able to actually put weight on it. The bone itself has a lot of nerve endings. So if there is a bone, it's like you're going to the doctor and they hit the nerve. It doesn't feel good. Just imagine if you put all your body weight on those two nerves from these two bones. So it is a misnomer. If it does happen that it's bone on bone, you really don't want to move your knees. So what we notice about this one is the cartilage is broken down. So the cartilage is broken down, so the knee joints are getting closer together. So what is cartilage? We know that cartilage is mostly water. It has a chondrocyte, it is cells, it has a collagen, it is a proteoglycan. This is what makes up the cartilage. It is around 2 to 5 millimeter thickness, and chondrocyte sends the nutrition, it gets its nutrition from synovial fluid and not from blood, because it doesn't have really any kind of a blood flow over there. And these layers, 4 layers, the superficial, the middle, deep, and calcified cartilaginous layer, this makes what we call hyaline cartilage. Hyaline cartilage is the total thickness of the cartilage that you have between your knee, on the surface of your tibia or your shin bone, and femur or your thigh bone. So hyaline cartilage is designed, it really is designed to last a lifetime of everybody. But unfortunately, due to what's going on with our body, due to improper misalignment, overuse, injury, or even being overweight, even their nutrition, our diet, these layers one by one starts breaking down. And this breaking down, you notice that you don't feel any pain at the beginning layer or superficial layer, just because there is no nerve ending over there. So the only way you can actually feel any kind of a pain if it gets deeper, to the deeper layer. That's why most people don't know that their knee is breaking down till it gets deep enough that it gets close to the calcified layer. That layer is still cartilage. It is not bone. It is the layer between the cartilage and the bone. Okay, that area you have a little bit of a nerve ending. That's when your indication, the first indication of that you have breaking down by giving you a little bit of a pain. So what happens with this cartilage? What do we know about this cartilage? This cartilage doesn't repair itself. The reason, it is avascular. It doesn't have any blood flow. There is no blood vessels over there. So this cartilage, any part of your body that requires any kind of a healing, it requires blood flow. If you don't get blood flow, you don't heal as fast, and you don't heal in some cases, just like cartilage, and it continuously breaks down. It is lymphatic, which means there is no lymphatic tissue over there. Lymphatic tissue and lymphatic system are for drainage. So if you notice that sometimes if there, let's say even in your calf area and your ankle, you notice there is some little bit of swelling, because lymphatic tissue is not functioning the right way. So our knees, when you see there's a swelling going on over there, one of the biggest reasons is because, well, there's no lymphatic, there's no drainage, okay? Again, it's aneural, as I said earlier, there is no nerve ending, so you don't feel any pain till it gets to the lower level. So it has a very poor reparative potential tissue. This is one of those tissues that requires a little bit more attention as soon as you get the pain, as opposed to wait till it might get better. Again, traditional options was, all designed to, relieve some of the pain, but not necessarily fix the problem. And some of them was NSAIDs, which is, it masks the pain. Some of the pain medication is bracing or cane, which causes a little bit of a dependency, because once you start using it, you kind of get, that's why I tell my patients, don't use it too much till you get better, because if you start using the cane and you use the bracing too much of it, you're going to be depending on this one. Cortisone, lots of side effects. We're going to talk about that a little bit later. Radiofrequency RFA, radiofrequency ablation. Okay, this is what happens. They go in and they basically deaden the nerve, the genicular nerve, that it provides some kind of a feeling to the outside of your, not inside, the outside of your knee, so you don't feel it. Unfortunately, it'll grow back. It'll grow back. Nerve usually grows back, especially those nerves. And of course, physical therapy, we call it this, broken system. The reason we call it broken system is because, you can do the physical therapy, you can get the muscles stronger, but if the tissue inside the knee joint, the cartilage, is broken down, doesn't matter how much you're going to get the tissue outside, the muscles get stronger. Doesn't matter how much you do that. We love it, by the way, but you have to get that component of the knee arthritis fixed too, before you notice that the physical therapy is actually working and working the right way. So let's break those down, those medications and the traditional treatment, and see why it works, why it doesn't work, and which one we like actually. Medication, over the counter. Of course, over the counter medication like aspirin, ibuprofen, naproxen, Tylenol. We always have this one. This is over the counter. You go take it. And of course, your doctor, every time you go, you see him, say, oh, just take a couple of these, see how you feel. It is anti-inflammatory at the very early stages when you feel it. Okay, to get the inflammation down, no problem, it is good. But one of the biggest problem with this one is most people think because it's over the counter, it must be safe. No, there are a lot of people going to the hospitals and actually could cause major problem to emergency room because they think it is over the counter. They continuously take more and more and more of it. And this could cause cardiovascular and GI toxicity, which basically throws you in a ER room, of course, vomiting syndrome. Narcotics, these guys, they know exactly what to do. They make all these pills look like candy. So I feel like I'm in a candy store. They make it so colorful that, you don't think this is dangerous. This is dangerous. You don't want to take too many of these things. In a very severe cases, you might want to take this just to calm it down. You don't want to be on these medications because of course, as you know now, how many people are dying and how many people are getting addicted to this. Some of the narcotic medication, this is some of the medication that you see, like oxycodone and hydrocodone, anything with the codeine, and tramadol. All these barbiturate have a lot of side effects. Side effects of Vicodin, just right over here on the left-hand side. And on the left-hand side, you see it says, more serious. If you just read some of the ones that it says more serious, seizure, slow heart rate, of course, pain. You're taking it for pain control, but you're still getting pain. Hives, itching, confusion, fainting. So you have to actually take another medication to counteract this medication. So that's why we say this type of a medication should be one of those things being monitored by your doctor, one. Second, use these things very sparingly. Don't get dependent on this one. Physical therapy, as I said, we love it. We do it. We have a great physical therapist. And one of the biggest reasons we have a great success in our clinic and with our patients, our success rate is great, is because the system that we brought, not necessarily just because of hyaluronic acid injections or PRP or stem cell, we have a system. The reason I say, hold off till you listen to Dr. Domingo. Dr. Domingo, he travels all over the country and he's teaching this to the other doctors, other medical clinics and hospitals, and teaching them what we do in our clinic. So our success is great enough that he actually travels all over the country teaching these things. And we are actually, last seminar, he was in the airport when we had that seminar. So corticosteroid. Every time you used to, again, just like those medication, it was like a candy. You go to see a doctor way back, they used to go to the doctor and they say, oh, it hurts, let's give you an injection. And of course, it's strong anti-inflammatory. Unfortunately, many side effects with this one. And on the right-hand side with that injection, with that serum, you can see that it says, do steroid shot, help knee arthritis pain, or cause cartilage loss. I wonder why they say that, For the corticosteroids, moderate to severe arthritis, they do that one. And they inject, in this country, now they inject only 3 injections per year. In Europe, they're a little bit more advanced in these things, and they give only 1 per year, no more than that. One of the biggest reasons is because it is a very strong anti-inflammatory that they put inside the joint knee capsule, which is encapsulated, which means it doesn't have no place to go. And that dehydrates that cartilage, dehydrates the tissue, dehydrates the meniscus. So because it is anti-inflammatory, you don't feel pain. It decreases inflammation. It does what it's supposed to do. but it dehydrates the tissue. As it dehydrates and you don't feel the pain, you're going to do a lot of stuff that you shouldn't be doing. We've had, patients, prior patients in high school, baseball player, kid coming over, he was a pitcher, and he comes over, he had a tendonitis. Well, dad decided that let's take him to the doctor, the orthoped, and the orthoped says, okay, let's give him a steroid shot. And he got the corticosteroid shot. Of course, the kid wasn't feeling it anymore. He goes and starts pitching and pitching harder and harder. He tore the total rotator cuff. And it's something that he could have actually avoided by taking some time off, stop the pitching, and let icing it in a way. From that to the major surgery, and his career is finished basically. So steroid, I'm not a fan. Only one, if after that you go ahead and do some physical therapy. It causes synovitis, post-corticosteroid flare-up, and of course chondrotoxicity, which is what I was talking about. So what do we do? All these patients have gone through all these, heat, exercise, weight control medication, and steroid injection. When it comes to us, we became somebody in the middle. So people, when they come over here, we are almost their last hope, last resort before they go ahead and get the knee surgery. And, they want to avoid the knee replacement. So of course, we do have the physical therapy. Of course, we have a special bracing, not just any bracing. We have a special bracing. We do hyaluronic acid or lubrication, and PRP and stem cell therapy. Let's break it down. Our motto in the clinic is don't replace, rebuild, renew, regenerate your own God-given joint, because nothing in nature can replace what was given to you. We cannot create that, duplicate that in the lab, okay? So stem cell, PRP, and hyaluronic acid is a new paradigm for healthcare. So again, we went through the structure of a knee. One thing I want you to look at over here, normal knee on the left-hand side, you can see the cartilage is nice and smooth. The one that you notice that on the right-hand side, that smoothness is gone. There is erosion you're gonna see. Sometimes you say loose body inside your body. Sometimes you feel like, between your knee joint, there's a grinding. That's what you're seeing. And you're gonna see osteophytes on the right-hand side, on the shin bone, right under the meniscus. That means your body is going through a lot of stress. Now, all these things, this capsule that you see right outside of your knee joint, all these things have a little bit of what we call synovial fluid. Synovial fluid or hyaluronic acid is the lubrication that it allows for your body and your cartilage to, one, regenerate, in a way, a decrease inflammation. Okay, so what is hyaluronic acid? It is a substance produced naturally in our bodies. We actually produce this thing, but as we grow older, the amount of it that we produce is not enough. That's one thing. And second thing is, it is not the viscosity goes away. It is not as good as it used to be. Just like when we were younger, we used to, regenerate. We used to do a lot of stuff, get up the next day, you do it again without having any kind of a pain. Now we don't, because our stem cells is not really, working the way it used to be. So when we isolate the hyaluronic acid, as I say, it's a very thick, viscous solution. When we isolate that one, we add that hyaluronic acid in the lab, from the lab, and we can inject it into your knee joint, and we refresh and refuel, in a way, your knee joint. Okay, it is purified and it derived from rooster's comb, or it could be genetically, engineered from the cells, different kind of cells like orthovisc, synvisc, genvisc. There are so many different kinds that it can be used with 1 injection, 3 injections, or 5 injections, depending on your condition, depending on which doctor we're going to talk to. And it's been used for many, many decades with a great results, okay? So the mechanism of the, action for hyaluronic acid is, it lubricates. FDA actually at one point they was thinking about it is a device because it is lubricant. So it lubricates, it protects your cartilage. It is anti-inflammatory because, well, it's a lubrication. It doesn't create any kind of a friction. So of course, there is no inflammation involved in that one. It is analgesic, which means no pain. It relieves the pain. Reason, well, it's not grinding against each other, and protects the subcondylar bone, that's where most of the nerve ending is, and that's where you feel the pain. All right. I just warmed you up. Dr. Domingo is going to be basically going through the whole thing and give you the good stuff. Matt, I'm going to send it right back to you.
Okay, great, Dr. Tony. And I just, can you maybe touch on the fact that you've had this treatment done for your own body?
Yes, actually, we've done just all the doctors in the clinic. We believe in what we do. So Dr. Domingo, he was a hockey player, and now he's actually coaching. So he beat up his body. So we've done myself. I was a wrestler. I played racquetball. I still do play racquetball, and soccer player. Many car accidents. I love speeding. So yes, I've done it for my low back. I've done the regenerative medicine for my low back. I've done it for my elbow. When I was lifting, I tore an elbow tendon. So we've done those things. Like I know Dr. Domingo, he can explain later on himself that I think he's done it for. Is there any body part you haven't done, Doc? Because I think you've done it for I've seen you doing it for knee, for your shoulder, for back, for ankle.
Pretty much everything. We do it all over the body.
Yeah. So yeah, this is great. And our neurologist has done it for his knees because he had bad knees. So he's been practicing for many years too. So thanks for asking.
Sure thing. If anyone has any questions now for Dr. Tony, just some quick ones, we can open up the chat real quickly for Dr. Tony. In the meantime, I will introduce to you guys Dr. Domingo. Like Tony said, he travels around the United States quite frequently and delivers presentations to other chiropractors or people in the medical field that would like to bring in regenerative medicine to their own clinics.
Actually, Matt, I'd like to correct you on that one. It's actually mostly medical doctors at this point. It's mostly internal meds and family practice.
Okay, great. And last time we were doing this webinar, he was actually in the airport on his way out to another presentation, but we're lucky enough to have him with us here. So I'm going to turn this over to you, Doctor, and you can go ahead with the PRP section of our presentation here.
So regarding the other aspects we have for care, and feel free to ask questions. So a lot of what we have with hyaluronic acid, physical therapy, and treatment is best incorporated with platelet-rich plasma and stem cells. So for those of you in the audience, I'd be curious to see if anyone, feel free to mark in the chat room, whether you have any experience with platelet-rich plasma, stem cell therapy, and any sort of regenerative medicine. The first topic I'm going to cover is platelet-rich plasma. Platelet-rich plasma, as you may have heard or learned about from other doctors, Google, the internet, friends or family, is your own blood. What you do, and you can see by this process here in the image, we're going to take your own blood. Your body has its natural healing factors, and we know this. You've had injuries, you've had cuts, scrapes, bruises, and you've been able to heal. You have healing factors in your body. And based on how your body functions, we're able to harvest that. We're able to take the level of platelets and those healing factors, concentrate it to about 3 to 8 times the concentration in your normal blood, and replace that. Put that into an area of the body that you need healing that's able to help you and help expedite the healing process. How does it work? So what we do with platelet-rich plasma, we're going to withdraw your blood. You're going to see in step 2, we're going to take a centrifuge and take that red whole blood and spin it down. As we spin it down, that's going to separate the blood. You'll get a red layer of blood cells. Those will be separated and they're heavier and they'll end up on the bottom. You're going to have a white separating gel, which is just our way of differentiating the weight and distributing the platelet-rich plasma versus the red blood cells. And you're going to get a combination of platelet-rich and platelet-poor plasma. And then by image 4, you'll see them inject it, whether it's going to be a rotator cuff, whether it's going to be for knee osteoarthritis, maybe an Achilles tendon. There's various options, the general purpose of which is to help with your healing process. Is PRP right for me? Now, PRP being your own body, keep in mind, we are expediting and enhancing your own healing process. So for PRP, it's used for most commonly chronic pain, people who've tried other conservative management, whether it be physical therapy, over-the-counter meds, steroid injections. A lot of patients who just want to avoid surgery, avoid taking the chronic meds. The age range has differed, based on your body and how you use it. We've treated people from 15 to 90, and this is a simple in-office procedure. treat anything in your body physically. And as you see later by certain images, there are a lot of people that are doing this for different aspects. You could do this for hair restoration. You could do this for the facelift. If you're a fan of the Kardashians, it's a possibility to do the vampire facelift and you look younger. The whole purpose is to make you look, or to make you heal, to enhance your own healing properties. So by taking your own blood and using the platelet part, for those of you who've had cuts, scrapes, ankle sprains, injuries, you know your body has its innate ability to heal. Now that given, we age, we have our issues, and how our body heals, not quite the same as it is or it was when you were 10 or 20. Your healing process hasn't been the same. So what we do by getting to that point of concentrating it, by withdrawing your own blood and concentrating into just the platelet-rich plasma part, that 3 to 8 times the concentration gives you an expedited, a boost, a powerful dose of your own platelets to help your body heal. Are there any adverse effects? So with your frequently asked questions, many people ask, what are the adverse effects? We are using your own blood, so there really is no adverse effect. There's no adverse reaction. Your body doesn't try to reject it. Is it FDA approved? Yes, the FDA has approved this. There are a lot of clinical studies. The benefit to a lot of the patients today, this is, with the way the United States is, we are a very litigious society. And because of that, we screen things. Everything has to go through the National Institute of Health. We have to do clinical studies. And then it's finally released into the public. Platelet-rich plasma has been available and effective along with stem cell therapy and hyaluronic acid all across the globe. It's just with the United States, it comes a little bit slower because we're more meticulous in our processes to make sure it's safe and to make sure there's no issues. So with those clinical studies, this has been around for at least 30, 40 years. We're slowly developing it. Other clinics are using it for various purposes, whether it's aesthetics, whether it's orthopedics, whether it's more internal. There are methods of which we can nebulize platelet-rich plasma. You can breathe it in and it actually helps with asthma, COPD. So there are a lot of options. It's more in the clinical study phase right now, but it is readily available to the general population. So that's platelet-rich plasma. Stem cell therapy, for those of you who are interested in stem cell therapy, is donated tissue in many cases. There are different types of stem cells. So when we're talking stem cells is another buzzword. And as far as stem cells go, there are different options of the quality of stem cells. So what we advertise, what we try to get to are stem cells that have a high efficacy, high quality, and the ability to help your body heal. Again, with platelet-rich plasma, we're deriving your own blood. Stem cells, the difference is we're actually using donated tissue. There are versions that I will explain that include your own stem cells, because that's going to boil down to a level of quality and quantity of those stem cells, which you'll see in the future slides. So stem cells are your own body's ability and material to serve as an internal repair mechanism. Your body does have the ability to heal. The platelet-rich plasma and stem cells, to just summarize and make it, and probably oversimplify it, is a level of regeneration of your own body, your own tissue. You regenerate your tissue all the time. You grow new hair, you grow new skin cells, you grow your nails. Those are created by stem cells and some of the basic building blocks of your body's ability to regenerate. They have specific functions. When we're talking stem cells, we're actually trying to break it down to the basic stem cell, the basic building block where it can differentiate. It can multiply and turn into different tissues, whether it be nerve cells, whether it be cardiac tissue. In a lot of the cases that we do with orthopedics, it's going to be more so for tendon, muscle, cartilage regrowth, maybe a meniscus in the knee. So when we talk about different types of stem cells, one aspect is mesenchymal cells. Mesenchymal cells are derived, and if you look at the picture, you'll see an umbilical cord. Now what happens for most patients, or all patients, and the quality that we hold ourselves in the United States and the FDA and the National Institute of Health, what we do is we get stem cells from donated tissue. That donated tissue from the umbilical cord, what happens is a mother has a natural birth. They decide, for myself, I am not going to, you're usually given the choice of cryogenically freezing your child's umbilical cord, to hopefully save it for their stem cells for your own purposes, your own use. Those people who do not want to save it or can't afford to save it, they have the option of donating. After donating it, what they do is they take that cord tissue, it's going to be donated, the patient will go through a pathology screen, the patient will be asked X amount of questions about their health, what's going on. It'll be given to the American Tissue Bank, the same tissue bank where you will get your donated heart, your donated liver, your donated lungs, and after that it's sent to another lab. That lab is going to further break it down, take the tissue that has been pre-screened, pre-qualified, and proven safe for patients, and they will break it down into the stem cells. With umbilical cord and mesenchymal stem cells, depending on where you get your stem cells, you have different qualities. You could get it from your blood vessels. You could get it from the amniotic fluid that surrounds the placenta and holds the baby in place. You can get it from Wharton's jelly. Wharton's jelly is simply the gel-like gelatinous substance that's actually holding the blood vessels in place, so very small amount. Depending on where you derive your stem cells will determine the quality and the types of stem cells, because your stem cells, when we're talking about the different injections that are available, they have different qualities and quantities. So it's like the same difference of going to Burger King for your burger or going to, I don't know, Ruth Chris for a nice quality Angus steak. You know, there's different qualities in different products, and that will play an important role in what's going to help you, what's better for you, because they have their different properties, their different ingredients. There's the qualities of the different quantities of growth factors, cytokines, mesenchymal cells. They're all different, and this is part of what we explain to you because they all have their different properties as far as healing. And in a general consult, we do like to itemize our treatments. We do like to be able to explain the differences of each property of stem cells, each product, and what your needs are. Everyone's a little bit different. Some people need more muscle for a rotator cuff. Some people need more cartilage generation. Maybe bare bones, you just really need more hyaluronic acid, and we'll recommend more hyaluronic acid treatment. So just like our treatments, just like the different aspects Dr. Tony brought up with physical therapy, we have different types of platelet-rich plasma, stem cells, and derivatives of their applications of how we want to inject it or put it into your body to be the most efficacious to give you the results you're looking for. One fun thing, and I love this picture, I mentioned growth factors, cytokines, mesenchymal cells. Your mesenchymal stem cells have a natural migratory effect. So depending on the area and how we do these procedures and based on what your body needs, you know, there is a whole aspect where the stem cells will help with your vascular supply. They actually help regenerate new nerves. They actually help with the immune system. They actually are anti-inflammatory. So all properties that basically enhance and create a very large environment for healing. I love this picture, again, partially because stem cells also have a migratory effect. Stem cells are looking for a job. They're looking for something to become. As I said, they're the basic building block of tissue. So as they're able to differentiate or change or turn into heart cells, liver cells, cartilage, or muscle, when they're going through your blood system, they have a natural migratory effect. They're your basic building blocks. Your little kid that hasn't figured out what to do yet, they're looking for something to do. They're looking to cause trouble. They're looking to get out there and be productive. So stem cells, there's actually a good research study, and for those of you that are interested, I'd gladly send it to you. There was one in Canada. By the way, I am Canadian, so I have to be proud of this one. He also did a great study on multiple sclerosis with stem cells. With the migratory effect of stem cells, there is a patient, they did a little test. They injected stem cells post-heart attack, and because of their heart attack, they'd use an MRI to document where the stem cells went. Their migratory effect showed that those stem cells traveled, although injected into the body, traveled to the heart and the highest area of inflammation. So this picture is great because the amount of space, the vascular supply, you know, your stem cells, depending on how they're placed in your body, have the ability to migrate and help with your healing. Just something that's just I find incredible and very powerful. I might have jumped the gun, but where do stem cells come from? Again, Donated tissue, umbilical cord is where we get them. There are talks of embryonic stem cells. So one of the biggest questions people ask, is this a Planned Parenthood donated tissue, aborted tissue stem cell? Which no, we do not do that. Ours are, again, FDA approved. We don't use aborted tissue. These are donated, and just like anything else you receive from a donated heart, liver, or lungs. Other sources of stem cells are bone and fat, and that's why earlier I brought up the issue or the prospect of quality versus quantity. So when we're looking at this, and I might jump a slide real quick. We're talking about the issue of quality versus quantity. We're talking about your stem cells. Like I said, PRP and stem cells, stem cell therapy, mesenchymal stem cells from donated tissue. You know, a lot of this can be based on your body, where it's coming from, and the quality. You know full well as we age, our body's ability to heal declines. We're just getting older. With stem cells and PRP, you know, depending on your condition, your age, and your general health, which all could affect the quality of cells, this is why we use different stem cells. Stem cells from donated tissue, a newborn, 1 in 10,000 is an active mesenchymal cell. So it's powerful, it's potent, it's extremely robust. It's just like your espresso shot. It's ready to give you a boost. As we age, we could go down, and you could see that at age 80, 1 in 2 million cells are mesenchymal cells, are active, really potent stem cells. So your quality's gone down. When we go back to, let me do this, go back to your sources, bone and fat, we can derive that from your own body. There are surgical procedures where they will take bone marrow, adipose tissue, and they will take that process and they will help harvest your stem cells. Now, the difference between umbilical cord stem cells and amniotic fluid stem cells that we use, with donated tissue, we know we have a small dose and a very high quality. With bone and fat, based on your age, your health, whether you have heart disease, cholesterol, diabetes, those all play into the quality of stem cells. But with bone and fat stem cells, although we're harvesting from your body, we have a larger source. You know, your umbilical cord, the amount of bone marrow and adipose tissue you may have, we could derive more stem cells. So it's a question of quality versus quantity. What we use is a safe, easy method, non-surgical. We're able to take the very strong, very potent donated tissue, and we're using those stem cells to help regenerate a level of tissue growth. Again, we don't use embryonic stem cells. That would be unethical. I jumped to this, and then bone marrow, again, as far as bone marrow, fat stem cells, there is a possibility, and unfortunately, you know, if anyone has heard or seen anyone go through a bone marrow transplant, it's a very painful procedure, a very large needle. It's like sticking a harpoon into your bone. Also, with surgical procedures, although there could be a benefit, and you could still get quality stem cells, there's still that risk of going through a level of surgery, going under anesthesia, and then going through the procedure. So it's a much longer process, much more in depth. You do have options. I find that because of the way the FDA approves everything, runs through everything, going through the National Institute of Health, donated tissue and stem cells from umbilical cord tend to be more safe and effective. Another option that we have is the amniotic fluid. So we went through bone marrow, we went through adipose tissue, which is your own body. We went through mesenchymal stem cells and derived from Wharton's jelly and umbilical cord blood. The next one we have is amniotic fluid. Amniotic fluid, depending on who you talk to, does have a level of stem cells. As we talk about quality, you know, when we're talking about quality, the biggest, most important factor when we include growth factors, cytokines, mesenchymal cells, when we're trying to get to quality stem cells, we're talking about mesenchymal stem cells. Mesenchymal stem cells have the highest quality in the umbilical cord with the Wharton's jelly. There are some, depending on who you talk to and the company where you get it, but amniotic fluid does have a level of stem cells, but amniotic fluid might have a little bit less. Amniotic fluid is the fluid that surrounds the baby. It does have a level of stem cells, and also it's important to keep in mind because it gets into different options and the different qualities of stem cells. It doesn't have the highest quality of mesenchymal stem cells, but does have its high quality of growth factors and cytokines. So amniotic fluid, in my opinion, is a nice step for stem cells. And if I were going to grade it and give you your top tiers, I would talk about mesenchymal stem cells being the gold medal. Your amniotic fluid stem cells being more your bronze, and your platelet-rich plasma being, the amniotic fluid being your silver, and the amniotic fluid coming in third with your bronze. Different qualities, different capabilities, all having a positive effect on patients and their conditions, but to what degree depends on, again, your severity and which product will be important for you to get the results you want. I kind of jumped this one with the umbilical cord. As far as umbilical cord blood cells, again, I find those to be the highest quality in mesenchymal cells. I've talked about migration and heart disease. I've talked about regenerating cartilage and what we do with helping rotator cuff or muscle strains. There's a lot of clinical studies, there's a lot of research out there, and you'll see this starting to come to light more in the next 5 to 10 years as we get more samples, more studies, more patients through this. But we're finding that the potency, the strength of these stem cells are helping people with Alzheimer's disease, lupus, multiple sclerosis, muscular dystrophy, Parkinson's, RA, spinal cord injuries, stroke, liver disease. You know, what we're using here, depending on the dosage and the quality, has been shown to help a lot of these diseases. So it's very exciting to be able to bring this to you and have it readily available. Years ago, as I said, this was something that's more readily available in Europe, whether you travel to Brazil or Portugal or Venezuela. Their restrictions, their FDA, their rules are much more lax. So they've had more experimentation there. But because of that ability and the general ability I mentioned earlier of being able to regenerate new nerves, to help with vascular supply, to break down and decrease inflammation, and to the general capabilities we're looking for with stem cells, the ability to replicate, to regenerate, and turn into other tissues in your body, it's been able to help help with developing new nerves, to help with the conduction and solving Alzheimer's disease, multiple sclerosis, muscle tissue, and muscular dystrophy. So there's a lot of different options out there that will be soon coming to light, and it's very exciting, and I'm glad that you guys are here and able to listen to this, because the future of regenerative medicine is continually advancing. I myself have worked with a lot of different procedures. I've learned how to do and teach people how to apply this as a nebulized version, an aerosol, or an injectable, or what we call fibrin matrix. We're able to put it into a gel and help platelet plasma or stem cells stay more localized. You know, these different applications are helping solve a lot of conditions. And again, it's all natural. Some of the best aspects, there's no known side effects because what we use is donated tissue that's been screened and gone through a pathology lab. There's no rejection and there's no issues. You know, to be honest, the worst case scenario, it doesn't work the way you want, but with what we do have a very high success rate. We've learned how to apply this in a fashion that is very successful, and our office compliance and patient success rate hovers around 90–95%. And I kind of jumped through that. So again, regenerative medicine is a new paradigm in healthcare. You know, it's non-operative, it's outpatient. It is something that we could use for orthopedics, for plastic surgery. It's an anti-inflammatory. It helps your immune system release pain and regenerating tissue. And here's some of the things we treat. So looking at these conditions, for those of you, and I've shared this multiple times during this presentation, you could be bone on bone. And on the left, you can see your image here with your normal knee and healthy joint space, quote unquote buzzword of bone on bone, and with no joint space or minimal joint space. Your shoulder, where you have joint space decreased due to osteoarthritis, your hips, where you could see the hips starting to just press on the pelvis or your hip bones, and it's causing more deterioration of the joint, or even arthritis in your cervical spine, where you go through a healthy curve or lordosis, and it straightens the spine, and you have more arthritis and degeneration. With these procedures, what we do, I highly recommend imaging. You know, when we do these procedures, depending on which procedure we do have an accuracy rate by using a fluoroscope to guide us and our doctors and nurse practitioner and staff to help place whatever we do, whether it's platelet plasma, stem cell therapy, or hyaluronic acid, to put it into the area of the body that you need the most. And you can see here how we do a general knee x-ray with the image on the left. Patient's knee is positioned within the fluoroscope. That gives us an image where we can look into the joint and watch the needle placement. This is an example of how we place a shoulder, where we could use this x-ray device or fluoroscopic live x-ray device to see the needle go into the shoulder joint. We use stem cell therapy and fluoroscopy and physical therapy, hyaluronic acid in combination for treatments most commonly in our office for treating and relieving osteoarthritis of the joints. And to give you the combination, when we're talking about, you know, we kind of threw a lot out there for you: platelet-rich plasma, stem cells, hyaluronic acid, physical therapy. By doing this in combination, our 90-95% clinical success rate is based on finding out what's better for you. Everybody in this audience, everybody here has a different condition, has a different age, has a different health status. Based on what you need, we have the different options of regenerating your body with something strong and potent like your stem cells. We could use the platelet-rich plasma and drive it from your own blood and help your body heal. We could use hyaluronic acid and replace the fluid in your joints, just like changing the oil in your car, to get results. Where you see here on the image in the before, on their right knee, they have virtually no joint space. By doing different combinations based on what you need and what's going on, always found out through a detailed exam and history and imaging, we could actually get results where we've seen joint space increase. And this is where patients are getting their relief. Although on this image on the x-rays, 8 months with just adding stem cell therapy, this patient was 63 years old, probably getting around with a walker and cane. With stem cell therapy, regenerating some of the fluid, the cartilage. 8 months later, you can see the results. Their follow-up visit shows they have increased joint space. Same on the image on the right, minimal joint space on the knee. The other side is a little bit more healthy. I can't tell which one is the medial or lateral, but by applying these procedures with stem cell therapy, possibly even combination with hyaluronic acid, platelet-rich plasma, you know, we're able to provide results where patients, from when they were told by their orthopedic surgeon they are bone on bone, we're able to get results where they feel better, they get the pressure off their knees, and they're able to get the improvement they're looking for, that active lifestyle they're looking for. So this is just a nice, powerful image on regenerative medicine. You know, the secrets of professional athletes and PRP. Honestly, you know, keep this in mind. When you look at this image, it's not just the athletes and the celebrities who are doing this to help with their ACLs, to help with their injuries, to help with, I guess, Angelina Jolie and making her look young, maybe slightly fake, but look very young. And, but when you look at these athletes and celebrities, you keep in mind, these people have extensive amounts of cash. When you have that kind of money, of course, you're going to buy yourself the best possible treatment. Every one of these athletes, every one of these celebrities, in some way, shape, or fashion, has used platelet-rich plasma or stem cell therapy to get them stronger, to heal their injuries, or just to make them look younger and grow hair. So with the question and answer, I've actually seen a lot of the questions, you know, and this is a valid concern. A lot of people have questions about insurance. There are cash and insurance-based programs based on these procedures that we could help you with. Big thing to keep in mind, it's going to be different from person to person. It's going to be different from your insurance. You know, your insurance is a contract. That contract, kind of whatever you sign, stipulates what may or may not be covered by the insurance. These are things we're gladly able to help you with. And we don't do any procedure, we don't do any treatment without you being fully informed of whether which procedure that we've gone through in this discussion of what's better for you, what your options are, what's going to help you get to the lifestyle, that quality of life of maybe you weren't able to walk much and now we want you to walk more. Maybe you just want to be able to bend your knees and pick up the grandkids. Maybe you want to go out there and run a marathon. As far as, hyaluronic acid being covered by insurance, that is definitely one option. It's going to be based on your insurance. PRP, unfortunately, is one of those that may not be covered by insurance. One of the newer options they have. Some workman's comp and PI are now covering platelet-rich plasma because they're realizing it's helping your case and your injury from work or your car accident to heal, but that's based on the insurance. And then stem cells, as of the stem cells I mentioned, the different qualities, Wharton's jelly, umbilical cord, that's not covered by insurance, but the amniotic fluid one that I mentioned is covered by insurance. So again, different options. There are cash, there are insurance-based options, and gladly we will go through the insurance, we'll go through your condition, go through a full exam, go through a general one-on-one free consult just to answer or at least give you an idea of what's going on with your condition, get to know you, and be able to give you at least an idea of what you need, what's going to get you better, what's going to get you the results or get you to the goals you're trying to get to, and how much it will cost. We're not
Do you have a few questions here, Doc, if you want to answer some specifically?
Sure.
Stephen asks, how do you know which treatment is right for you?
All right, Stephen, as far as what treatment's right for you, it's really based on your condition. It's also based on your goals. What are your goals? When I'm bringing up some of these different stem cells, these different regenerative medicine options, is your goal to get to running a marathon in the next 2 months? Then I'm always going for the strongest, most potent, and honestly most expensive stem cell therapy with Wharton's jelly or exosomes. I didn't really talk about exosomes, but it's just a high quality, and that type of injection, that kind of procedure will get you back to that lifestyle faster.
Okay, and Terry and Jeff both asked, touching on the timeframes for the healing, and so Jeff asked, how long does PRP treatment help with the joint pain? And Terry said, after doing the therapy, what is the time frame before you might have recurring issues?
I have to defer to a general answer to that. It's based on condition and it's based on severity. Like Dr. Tony mentioned, when he went over, if you remember that one of the previous images, when they were talking about the level of osteoarthritis, and there was a image showing different levels of osteoarthritis. The sooner I get to any condition, whether it's osteoarthritis, whether it's treating cholesterol, whether it's treating diabetes, the sooner you get to anything, the better the results, the longer the lasting results. Also keep in mind, how do you use your body? If we're going to help heal your knees to get you better, we can definitely do that. It's more a question, are you going to just go back to regular activity? In which case, a lot of patients, we don't see very often. Once we do put all our tools, all our procedures into a program that's going to help you, maybe if you're having a basic lifestyle of just doing average activity, it's something we may not have to see you for a very long time. But if you're going to do our procedures, do our program, get better, and go around running a marathon every month, you're going to wear and tear your body. It's the same concept as driving your car. I know newer cars, and if you have your electric Tesla, you don't have to do this. But every 3,000 miles, you were always recommended to change your oil. Same thing goes on with your body. If you're going to go 3,000 miles in one day, great, you got to change your oil, do some procedure, do something to help your body. If you're going to go 3,000 miles in 6 months, you might not have to do it as often. So things to keep in mind as far as your goals, what we can offer, and what's best for you.
Can I interject over here? I agree totally 100% with Dr. Domingo. And one more thing that I think we need to understand is, depending on your age, depending on how much of a breakdown there is, remember, it is a mechanical issue. It is not a chemical issue. That's why we are saying that if you're using any kind of medication is chemical. If you have a chemical problem, then the chemical issue should fix it. There's no problem, okay? But right now, osteoarthritis, it is mechanical. It is alignment. That's why the physical therapy part of it is going to help post injection, or then depending on what you need. It's not one size fit all. It's like putting an insert in your shoes. You know, you can't go get the same insert from from a shelf for your feet as somebody else who's got a different arch in their feet and put it in there. So that's why where the consulting comes in picture. Unfortunately, now we're not doing any kind of a consult in a group anymore. So that's why we're doing the webinars, and we're doing the one-on-one consult in a separate room away from the patients that we're seeing right now. We stayed open throughout the whole coronavirus. I hope that kind of answered a little bit of what you were asking. How long does it last? How long does it last? Depending on what you do. If you continuously do what you were doing to begin with, that it broke it down, and if you don't change the alignment of your body, well, it's going to break down no matter what we put in there, from the top of a line stem cell to the lowest one. It doesn't matter. If you continuously do what you were doing and you don't change that, it'll come back. You're going to get it again. Okay. You need to change part. That's why the system that we have, it works, because we help people actually change that part of it. That's why it lasts longer.
Okay, and then we had a pretty detailed question from Jeff. Jeff, if you type a 1 in the chat, if you want to ask this question, out loud, maybe I can unmute you and be able to ask the doctors more specific.
I could read it if that's easier.
Sure.
So Jeff, I'm just going to present this. I could see it in the chat. The last 3 months, okay, there's 3 different doctors telling you definitely need a knee replacement. It's your only option. You've had physical therapy. It hasn't really helped with your pain. There's 3 surgeries, including ACL repair back in the 90s. You don't want a knee replacement. So generally with your options, the biggest thing I'll talk about, your knee replacements. Let's think about this. Your knee replacements are artificial prostheses. They're not necessarily designed, unfortunately, to last the rest of your life. They actually have about a 10 to 50, they're graded for 10 to 20 years. So if you plan on living more than 20 years, knee replacement is something that if you do at a very young age, something that you have to really consider, that are you willing to do it again? It's not easy. Knee replacements also have their side effects. You are going through surgery, you're going through anesthesia, and it's not a one size fit all. As far as knee replacements, there's on average, about a 60% success rate. Our office, as I mentioned during the presentation, we have around 90-95% clinical success of helping people get better. Total knee replacement has a 60% success rate, and the reason being for that, besides the fact they were only graded for about 10 to 20 years to last, they also are not designed like going to your DSW or shoe store. That 60% is a 10% increase over the last 5 years of their success, because they're getting into 3D printing and more technology to help with the knee replacements. But knee replacements still aren't a one size fits all. Look around the neighborhood at the very few people that are walking around. Everybody has a different body type, a different shape, different weight. And your knee replacements don't necessarily have the selection to give you a size that fits you perfectly. So there is a level of risks with going through platelet-rich plasma, stem cell therapy, hyaluronic acid. The worst case, there's actually no known side effects. Hyaluronic acid is actually so safe, it's used as placebo in diabetic patients, that by using these procedures, it gives you a fair chance to get better and help you avoid surgery. So it is an option. Once you go total knee replacement and have a prosthesis, your options are now limited.
Most of our patients that they come over here, a lot of patients that they come over here, they already have one knee replaced, and they don't want to go get the second one done. They know that what the procedure was, they know what they went through, and they don't want to get it done again. And once they see what they get and they feel as good as they do, well, kind of once you go under a knife, you can't take it back, but they wish they wouldn't have. Okay, so one thing you have to remember, when you go through the knee replacement and total knee replacement, it takes you around 6 months before you can actually get back to what normal, get rid of the pain. You're still gonna go through the physical therapy part of it, a lot of pain. It takes, and this comes from the orthopedic surgeon himself, it takes around 2 years before it gets as good as it gets. Not necessarily it gets back to normal, but as good as it gets. So knee surgery should be the last resort. Ours is actually, that's what we are, the one that is between knee surgery and just the physical therapy and other therapies. We are in here, that's why, as I say, it's a new paradigm for healthcare, to regenerate, so you don't have to get that knee replaced. Remember, orthopedic surgeon, their job is what? To do surgery. So of course they're gonna promote that, okay? My job is to, it's still there. That knee surgery is gonna stay there, no problem. If this doesn't work, then you have that. But for most part, we are getting great results and patients are avoiding the knee surgery. So always think about that one. Once you go under the knife, you can't take it back. For us, is one day you come over, you get the injection and you go home. Of course, same way you came, the same way you go home. But we want to teach you how to get your body back to as normal as possible by doing the right physical therapy as well.
Okay. Well, if anyone else has any questions for the doctors, please take the time now to maybe type a 1 in the chat or answer it, submit a question for the Q&A. Otherwise, thank you all very much for sticking with us here to the end. Those of you who did request a consultation, Rita in our office will be reaching out to you guys over probably just tomorrow and looking to schedule those consultations with you directly. So if there's no more questions here, we'll leave it open for maybe another minute or so. Then just make sure you guys have a good night, and we'll hope to be speaking with you guys again soon.
Thank you, Doc. Thank you, Matt. Thank you, everybody.
I guess I don't see any questions in here, so if you want us to leave this open, drop a 1 in the chat. Otherwise, we will go ahead and say good night, and we'll speak with you guys again soon. Looks like we're wrapped up. Okay, thanks, guys.
Thank you. Good night.